So hello, everyone. This is Chris Forrest. I'm a professor of pediatrics at the Children's Hospital of Philadelphia and the University of Pennsylvania School of Medicine. I also direct a national network of children's hospitals called PedsNet. PedsNet is organized in order to promote a national scale pediatric learning health system. We'll hear a little bit more about PedsNet in this talk. And then finally, I direct a learning health system scientist training program called PedsNet Scholars. Today, I'm going to talk with you about 3 phases of the Learning Health Systems Researcher Competencies Initiative. The first phase is its origins. I'll talk about the case and why we need Learning Health System Researcher Competencies and how they came about. Then I'll talk to you about the developmental process that we used, as well as the content of the competencies that were generated through that developmental process. And I'll conclude with a few comments on our training program that is designed in order to produce the next generation of learning health system scientists. So let's get right into it. Let's start with the origins. In 2007 to 2014, there were a series of publications from the Institute of Medicine, now the National Academy of Medicine, that laid out the framework, the conceptual model, and some practical examples of what was initially called the learning healthcare system. Now we're calling them learning health systems as opposed to learning healthcare systems. And I think that's an important distinction. Any health system that at any level can continuously and routinely study itself and improve itself is a learning health system. So it's not just limited to medical care or healthcare delivery systems. A learning health system could be based in a community. It could be a public health agency. Could be a set of community health centers. So it's a very broad conceptualization, far beyond the initial notion of healthcare delivery. I was lucky enough to participate in a number of those early reports, and the way I started to think about a learning health system was really in very simplistic terms. So imagine a piece of paper, and on that piece of paper, in the middle are people, populations that are really the target of learning health systems, right? What we're trying to do in learning health systems is improve the outcomes of people, as well as those systems of care that serve those individuals. But the key notion about learning health system science is that it's focused on outcomes. And then linked around that middle core of people and populations are 4 domains: research, improvement, informatics, and engagement. So the way to think about learning health system science, is that it's the confluence of applied clinical research, improvement/implementation science, informatics, particularly leveraging existing electronic health record data, and stakeholder engagement. And we'll flesh that out much more, but these key domains, I think, are derived from the initial IOM reports, and they're also specified in an article that we wrote in Health Affairs in 2014. I'd like to briefly mention our own journey to develop a national scale pediatric learning health system, because it actually bears on the origins of the Learning Health Systems Researcher Competencies Project. So we started with the conceptual model from the Institute of Medicine, and then we obtained funding from Agency for Healthcare Research and Quality to generate a prototype, a prototypical learning health system in one specialty, pediatric gastroenterology, and one disease, inflammatory bowel disease. That prototype is now called Improved Care Now. And if you're interested, Google Improved Care Now. They've been doing great work on improving the outcomes of children throughout the nation with inflammatory bowel disease. After that successful prototype, we then received funding from Macquarie to take our learnings and scale it up across the nation to create a pediatric infrastructure. And we're now training the next generation of scholars to leverage that infrastructure in order to promote outcomes across the nation of children and their health systems. A little more about that prototype project. We started with a community of people, and learning health systems science is really fundamentally a A science organized around our social relationships. You start with people, you start with stakeholders, you start with a community organized around a common purpose. The common purpose for Improved Care Now was to improve the outcomes of children with inflammatory bowel disease. We built a digital infrastructure that allowed us to integrate a variety of improvement applications, population management, pre-visit planning, etc. The initiation of those applications, plus the use of improvement methods, generated this chart published in Health Affairs. On the y-axis is remission rate. Each dot is the proportion of children with inflammatory bowel disease visiting an Improved Care Now practice in a given month across time. And what you're seeing is that the chance of remission, which is feeling great, I've got no symptoms, my disease is quiescent, went from 50% in 2007, 2008 to about 80% by 2014. That is short 7 years, 30% absolute increase in outcome, no new drugs, no new surgeries, purely by leveraging the learning health systems model. Pretty cool. We also took the data that were generated from the digital infrastructure that we created to serve the improvement needs and used it for research. So what research project did we do? We did the one that was most important to stakeholders. So we asked families and clinicians, what were some of the key areas of uncertainty that really bothered them? And if they had evidence, it would actually help them make decisions. And what they told us is that biologics like Remicade and Humira, these so-called anti-TNF alpha inhibitors, were tested in adults, but they were never tested in a clinical trial in children. So what we did is we ended up using the artifacts, i.e. the data generated from the digital infrastructure that supported improvement activities for research. And we used a variety of methods that enabled us to evaluate and create pseudo trials. In other words, 6-month observation periods of kids who started out quite sick, who were moderately or severely ill. And we knew they were moderately or severely ill because we were collecting that information through the digital infrastructure that we set up. And some of these kids initiated biologics. Some of them didn't. They went on standard of care, thiopurines and steroids. And what you're seeing here are two outcomes: clinical remission as determined by the clinicians, or steroid-free remission, clinical remission and not on steroids. The top line are kids who initiated biologics. The bottom line are kids who didn't. And you see there was a 50% increased chance of going into remission if you initiated on the left, and a 74% chance of being in steroid-free remission if you initiated biologics on the right. And it turns out that the adult randomized clinical trial, published in New England Journal of Medicine, costing about $12 million, had a rate ratio for steroid-free remission of biologics versus standard of care of 1.72. And our estimate was 1.74, almost dead on. This study was done in a matter of a few weeks. After we figured out the methods, it cost us in the range of about $25,000. So I took all those learnings on how to set up a digital infrastructure, what are the regulatory requirements, how to use that for improvement, how to use it for research, and I brought that back to ARC. ARC was our funder. One of the things I like to do after my research projects is to present the results back to staff at the sponsor. And December 2014, we presented the results, and then after that presentation, we had an impromptu discussion with ARC leadership. And one of the things I raised is that, this learning health system model is catching on across the nation. There are more and more health systems that want to become learning health systems. However, we don't have training programs for learning health system science. That was in December 2014. And so that really, in my view, was the origins of the learning health system researcher competency, because by August 2016, it took them 2 years, ARC had secured funding to develop the learning health system researcher competencies. And so this project was called Training the Next Generation of Learning Health Systems Researchers. it was the project that I co-led with Kamala Mistry, who is a staffer at LeaRRn, to develop core competencies that could serve as the basis for training programs for learning health systems researchers. Let me tell you a little bit about how we developed the competencies, and then I'll dive into the competencies in this part of the talk. We first knew that we wanted to generate not objectives, but competencies, which are actually the outcomes. It's the outcomes of learning activities. So what we wanted to define is, what are the knowledge bases? What's the know-how? And what are the skills that all individuals who do learning health systems research should have, i.e., what are the core competencies? We knew that each competency would have a set of learning objectives that could be didactic, that could be experiential. Didactic meaning sort of like self-directed learning, MOOCs, or webinars. Experiential approaches would be things like your actual research project. Excuse me. And that the success of a program could be evaluated by the degree to which the competencies were attained. We also recognized that there were different types of competencies, that in generating the language for the competencies, we needed to articulate whether it was a knowledge, kind of something you should know competency, something you should know how to do or know about, or something that you should be actually very skilled in. So an example is, learning health systems scientists should be knowledgeable about complex adaptive systems, but they should be highly skilled in engagement, in the engagement of stakeholders. And you'll see that this concept of knowledge or know-how or skill reflected in the competencies themselves. We learned a lot about how to run a multi-stakeholder informed competency development project back in 2008 and 2009, when we developed the doctoral core competencies for health services research. These competencies actually formed the basis for LeaRRn's T32 programs that were designed to train pre-doctoral students in health services research. So we took what we learned there and we built out this methodology, which I think was quite strong, and it was actually fun to be part of over the course of a year. We started with a very comprehensive literature search on all articles that dealt with any part of the conceptual basis of learning health systems. We then did an inductive content analysis to derive domains, and then we vetted that work by a variety of experts. We formed a technical expert panel, a TEP, that met multiple times, both over the telephone as well as face-to-face. And that the TEP also engaged not only in a consensus development process to generate and then prioritize the competencies, but it also engaged in a Delphi process. And then we sought additional expert opinions outside of the TEP from leaders across the country. And you can see the flow. We ended up with the literature review, the consensus development process, the key informant interviews, and the Delphi process, drafting competencies, evaluating them, prioritizing them, revising them, until we got to a point where we reached equilibrium and we generated a product that the TEP was quite proud of. Here are the members of the technical expert panel, leaders from across the nation, individuals who were leaders in improvement science. Several individuals were directors of training programs in health services research or patient-centered outcomes research. We had funders from NIH as well as PCORI involved, as well as LeaRRn staff. Here's the list of our key informants. Again, we tried to branch out of the expertise that we had localized within the TEP, and we engaged individuals who had deep expertise in learning health system science. We talked to some of the leading authors on learning health system science, as well as leaders in the training of individuals in learning health systems research. So we started with the IOM, National Academy of Medicine, definition of learning health systems. We didn't want to recreate a definition, so we said that's our definition. And from that definition, we derived this concept of a focus on outcomes, engagement science, informatics, research, and improvement. But we thought it was very important to define what a learning health system researcher is. So if I'm going to become a learning health system researcher, who am I? How do I describe myself? And so in the right part of this slide, and the kind of the orange box there, was our first definition, that a learning health systems researcher was a professional who conducts research in routine healthcare settings, generating new evidence that health systems can rapidly implement to improve quality and patient outcomes. We got a lot of feedback about that definition. In general, you can read some of the specific comments on the lower part of the slide. Get rid of the word routine. Learning health systems can be outside of routine settings. It might be an emergency room, or it might be a community-based organization. It might not be a routine healthcare setting. So remove that. Also, the notion of the collaboration, that learning health systems researchers don't operate in the ivory tower. They're actually out and about, working with patients, working with clinicians to define the questions, working within health systems, understanding health systems strategy, understanding the problems that health systems are facing, and defining research questions in that way as well. So based on all that input and a lot of work, we came up with this definition, which we put in our publication that was, I'll reference in a bit, in Health Services Research in August 2017. Here's the definition of a learning health system researcher. Now, before I get to reading that, I want to talk about this notion of, should we be talking about learning health systems researchers or learning health systems scientists? And the Agency for Healthcare Research and Quality now funds 11 centers of excellence. I lead one of those to train junior faculty within a K-12 type program to become learning health systems scientists. We've changed the word researcher to scientist because these individuals are skilled not just in research, but data science, improvement science, engagement science, team science, and implementation science. So the word the word scientist seems more appropriate than researcher. Okay, so a learning health system scientist is an individual who is embedded within a health system and who collaborates with its stakeholders to produce novel insights. That's research, what I'll call the afferent arm of the learning cycle, that can be rapidly implemented, i.e. the efferent arm, or improvement and implementation to improve the outcomes of individuals and populations, as well as to improve health system performance. So key concepts are: the individual is embedded. That is, they are part of the health system, or they're an invited guest, and they have independence. Their work is not going to be squashed by the health system. They're learning. They're producing new knowledge that then can be rapidly fed back. We use the word health, not healthcare systems, to make it a broader perspective. Very important concept is the notion of stakeholder collaboration, i.e. engagement, and that we link in this definition evidence generation, research, with implementation. And finally, and I think actually most importantly, the focus of learning health system science is on outcomes. It's on health. It's on well-being. It's on efficiency. It's on the effectiveness of care. So in asking our expert panel, as well as our key informants, and scouring the literature, we identified these 7 unique attributes of learning health system scientists. They're able to conduct applied science. They're able to do research in busy health and healthcare settings. They're able to do it rapidly. Some of these projects may only last 30, 60, 90 days. Some might last 5 years. But that the notion of rapid learning is core to what a learning health system scientist does. They're embedded. They're able to conduct team science and coordinate across multiple disciplines, engaging collaborators at multiple levels. Some projects might have patients, clinicians, health system executives, all defined as potential stakeholders, and they become collaborators in the co-production of the research. They're able to both disseminate their results as well as implementing them back at the point of care. They have deep expertise in the technical, i.e. the digital, regulatory, improvement, and social infrastructure that comprises the platform that underlies learning health system science. And they have expertise in gathering data from routinely generated data from electronic health records, which are generated from routine encounters. So with the notion of the learning health system scientist and these unique attributes, we were able then to derive 7 domains, which organized our competencies. And we wrote specific competencies for those 7 domains. And I'm going to go through them now. I'm not going to go through the individual competencies because that's a lot. I'd point you to our publication. So the first domain is system science. Learning health systems scientists ought to know all about how healthcare is financed, how it's delivered. They ought to know for their own health system how it's financed and what its strategy is. They ought to know how their health system that they're working in improves performance and what outcomes matter to that health system. They need to use systems thinking in developing and implementing their research and improvement projects. And they ought to be quite knowledgeable about complexity theory and complex adaptive systems. Second, they need to be able to ask meaningful questions. Meaningful to whom? Well, meaningful to the stakeholders. And this is a really important, it's almost the secret sauce of learning health system sciences. That is, you're not identifying projects that are just meaningful to you and to your 5 best friends. Your research should be of value to a large number of individuals who are in the system that you're focused on. So your system could be a critical care unit. It could be 20 critical care units across the country. It could be the hospital. It could be the care management infrastructure of a hospital. There are multiple ways to define your system and to define the stakeholders within that system. But what's really important here is that you elicit the priorities of the stakeholders in the system that you're targeting, and then you prioritize those elicited topics and choose the ones that are most important, such as when I talked to you about our prototype, our Improved Care Now prototype, we didn't just do any research that was of interest to us. We actually asked the patients and clinicians who were part of the system what would be the most important, meaningful project to them. The second type of expertise within this broad domain that learning health system scientists should have is the ability to evaluate scientific evidence. Sure, they should be able to evaluate the literature generally, but most importantly, they ought to be able to translate the biomedical literature, new knowledge, to the specific context of the local health system. It's not enough to just know whether something works or doesn't work. The question is, how do you make it work within our health system? Third, research methods. We wrote the competencies with the understanding that individuals who are becoming learning health system scientists should have some foundational knowledge. They should have, and now in our faculty development program, we require master's level competence in research methods. So what we're doing here is we're building on a foundational set of knowledge bases and skills for research. What are we adding? We're adding knowledge and skills on how to conduct pragmatic studies, particularly pragmatic clinical trials that may involve complex interventions like improvement bundles or complex or surgeries, et cetera. Importantly, we talk a lot about how to conduct research in real world settings. How do you have to adapt your research design so as you don't affect routine care or care that occurs in everyday settings or clinical operations, et cetera. And you need to be able to match the research design and appropriate statistical techniques to the question. And finally, individuals ought to be able to understand what are the most important outcomes to patients, oftentimes as patient-reported outcomes, and they ought to have the knowledge on how to select the appropriate patient-reported outcome tools to address the outcomes of interest, as well as system-level outcomes such as value and efficiency. The fourth domain is informatics. This is, if you think back to that image I was trying to get you to form in your mind, outcomes in the middle, and then there are 4 parts around the middle: informatics, engagement, research, and improvement. So this is one of the 4 pillars sort of holding up outcomes. Learning health system scientists need to be skilled in understanding electronic health records and how to use electronic health records for research, quality improvement. They ought to be able to know how to link EHRs to other data sources, such as clinical registries or health plan data or school records and pediatrics. And they ought to know a lot about how to provide decision support to bring information that's obtained back to the point of care so it can be used when and where it's needed. They should have knowledge about a variety of what I'll call just data matters. The quality of routinely collected data. How do you evaluate the quality of EHR data, both its structural quality, is it present, as well as its semantic data quality, are they plausible values? You ought to know about data sharing and common data models, how to take data from multiple source systems and structure it in a way that it's standardized in a common data model. You need to know about terminologies, clinical terminologies such as SNOMED CT for diagnoses or RxNorm for medications. And then finally, they ought to be skilled in the use of research project management tools, data management tools, as well as data collection tools such as REDCap. The fifth of our initial 7 domains is ethics. And here, it's very important for these scientists to understand the gray zone between research and quality improvement. You know, they're not two boxes that abut against each other. They're really more like Venn diagrams, and knowing a particular project is research versus improvement is actually quite difficult. So in our own training program, we spend a fair bit of time talking about that distinction and reading various articles that help to characterize research versus improvement, and then the ethical obligations for research versus improvement. We also talk a lot about, and I think these scientists ought to know how to write informed consent that is pithy, you know, it doesn't go on for a lot of pages, and protects the rights and the privacy of patients. And they need to know, because increasingly this is the kind of research that we're doing, about multi-institutional IRBs, the use of a single IRB, an IRB of record, as well as relying IRBs, et cetera. And then finally, we spend time, and we think it's important to focus on conflicts of interest, knowing when you have a potential conflict of interest and how to manage those. The 6th domain is improvement and implementation science. And we find in our training programs, this is the area that our scholars are perhaps weakest in. So we've actually started to put more and more curriculum into our training program on improvement and implementation science. So for sure, learning health system scientists ought to know how to collect quality metrics and use them, but they also should be skilled not only in research methods, but in the methods of quality improvement and implementation sciences. One of our experts said that purists might argue that improvement and implementation science should be separate domains, and I'm not going to disagree with that. But the point I want to make here, though, is that in defining these competencies, we sort of tried to balance a parsimonious set of domains with purism, if you will. So in this case, parsimony won out. And another expert said that for learning health systems researchers, implementation science may actually be more relevant than QI. I'm not sure I agree with more relevant, but certainly it is relevant because that's where they can add significant value across systems, either by adopting a successful of the intervention from the outside and adapting it to the local context, or by sharing a successful intervention within their local context with others outside of their system. The 7th domain is engagement, leadership, and research management. A couple of things kind of pushed together, I think, but still the concepts of stakeholder engagement, knowing how to engage stakeholders of all types, how to co-produce outcomes with stakeholders, and then how to disseminate back to stakeholders is critically important, and is one of the most important types of science that, again, it's one of the pillars, it's one of the 4 pillars that learning health system scientists ought to have. They need to know how to be part of and how to lead diverse multidisciplinary teams. And they should be skilled in research leadership, how to develop a novel, how to envision, let me say it this way, how to envision their research program, and then develop strategies, research projects that can then pursue that research program, how to get people aligned around your vision, et cetera. So the actual skills of leadership, I think, are quite important. In general, the skills of leadership are quite important for the learning health systems scientist. Now, through our work with the other centers of excellence that are now training junior faculty to become learning health system scientists. We've reevaluated the competencies, and the 7 domains are working quite well, but we've decided that there's an 8th domain. Now we're going to call it health equity and justice. And although this was embedded across a sort of a cross-cutting theme in the 7 domains, we think it in 2021 deserves to be a standalone domain. So what do we mean by that? Learning health system scientists should be able to detect, evaluate, and mitigate disparities that exist because of socially determined characteristics. They ought to understand how structural biases, social inequities, and racism, how their effects influence health. And they ought to be skilled in not just clinical informatics, but also population health informatics, skilled in how to conduct surveillance and how to evaluate social behavioral determinants of health and GIS systems. All of those domains, except for that 8th domain, are summarized in this report that came out in August 2017. So recall that December 2014, we made the case that learning health systems science is an emerging field. We need to start training people in that area. 2016 to 2017, we developed the competencies. We published them in 2017. And now part 3, implementation, AHRQ, a month later after that publication, issued this RFA for training programs to be organized around the 30 plus competencies in that health services research article. They asked programs to submit applications to say how they're going to create learning experiences to inculcate those competencies. From this training, from this announcement, 11 programs, as I mentioned, were funded, and we were one of the recipients. We've now just enrolled our 2nd cohort of scholars. This is our first cohort, 10 scholars. By the way, we have a lot of material about our training program on the PedsNet website. Just go to pedsnet.org/PedsNet-scholars. We have, I think, a bunch of our talks recorded up there, our curriculum, and a variety of other resources that you might find valuable. So 2 slides on our training program. We have a very important application process. It's a national training program that allows any faculty member at one of the 9 PedsNet institutions to apply. Our institutions run from Boston to Seattle. Each institution has an institutional leader who runs a local selection process, and then based on that process can submit up to 3 applicants for consideration by the executive committee, which is composed of 1 individual from each of our institutions. We have at any one time 5 scholarships that are provided by ARC, but we also allow faculty to be institutionally funded. And in fact, the majority of our faculty in our training program are institutionally funded. So the institutions themselves are now paying for these learning health system scientists to develop the skills that will enable them to bring back their knowledge, bring back their know-how to their local institutions to start to learn, and start to improve and enhance outcomes. It's a 2-year program. There's an option for a 3rd year, and the application process requires that the individual identify a topic that's meaningful to stakeholders. So they write a short proposal. They need to have a research mentor, and importantly, we ask that they have a health systems mentor, like a chief quality officer or a chief operating officer, a mentor that can help them understand how the health system works, and then connect them to others in the health system to learn about their own health system, to learn about the strategy, to learn about how it's organized, how it's financed, what's important, what are the priorities, etc. And then here are the methods. After we enroll our scholars into the program, they create an individual development plan based on the areas that they would like to enhance. Some people want to focus more on data science. Some people want to focus more on, say, pragmatic clinical trials. So that's great because that's their area of specialization. Everybody has a set of core competencies that are outlined in that health services research report. They have a mentorship team locally. We also attach a mentor from the PedsNet leadership team. So there are 4 of us, myself, Don Goldman, who is the Emeritus Chief Science Officer from the IHI, Peter Margolis from Cincinnati Children's, and John Finkelstein from Boston Children's. It's a mix of individuals with research and improvement expertise that we can bring to the scholars. And we nationally in our leadership program We don't mentor them on their research project that happens locally. We're more interested in kind of the life course mentorship, helping them define their career path, because this is a new field. Some of these individuals may become chief medical information officers. Some might become chief quality officers. Some might become independent investigators, and we have a mix in the training program. We do all of our teaching sessions as video casts, and we do didactics with lots of discussion as well as works in progress. We have a structured set of readings. We also do online courses. We take advantage of MOOCs, a couple of them that have been developed by IHI that are done on in parallel. So the students or the scholars do the courses over the period of about 2 months, and then we use the content of the courses for discussion. Each institution presents how they organize their learning activities, how they organize their quality enterprise, how they organize safety, how they organize research, how they're connected, so that the scholars get a sense of how the diversity of ways in which institutions are establishing themselves as learning health systems. And we also ask our scholars to participate in institutional committees so they can better understand the needs and priorities of their home institution. So that's what I wanted to talk to you about. I hope I made the case that there is a need for training programs to produce learning health system scientists. It was quite dramatic that the concept of a learning health system science training program sort of emerged at the end of 2014. And by 2016, we were developing competencies. And by 2017, we were competing to become a center of excellence. And by 2019, we were launching our training programs. Thank you very much. I really am pleased to have provided this talk to you and shared our experiences. And I'm looking forward to our discussion.